So we're going to be talking about a story about three people, the three people being Amar, Akbar and Anthony. This is going to be a story about laziness and ignorance. I'll tell you how it is. So Amar, Akbar and Anthony were of similar age. They were born during the same time. But there was one problem with these three people, that Amar had congenital cataract, whereas Akbar had Anisometropia and Anthony had Squint. The point is, all of these three people had this disorder to the unilateral eye. So Akbar had unilateral Anisometropia, Anthony had unilateral Squint, whereas Amar had unilateral congenital cataract. Since till the age of 5 years, all these three people used to, play together. They used to enjoy together, and the parents of Amar, Akbar and Anthony did not worry much. They were like, it's fine, ek aak to hai, one eye is there, so let's take care of them the same way they are. But on the 6th birthday of Akbar, they were trying to cut the cake, and then they suddenly see Akbar was not able to cut the cake. He wasn't able to locate the cake. He was cutting the table. He was trying to cut the table. Likewise, Anthony and Amar were trying to guide Akbar to cut the cake on the opposite side. So basically, all these three people were not able to see in their unilateral eye also. They had defective vision on their unilateral eye also. So this was a mismanaged and birthday gone wrong basically. So what am I talking about? I'm talking about amblyopia, which is also called as lazy eye, and I would also denote it as ignorance eye, because amblyopia is a disorder in which there is partial reversible loss of vision. And if you were to examine it, if they come to the OPD, Amar, Akbar and Anthony, if you examine them, there will be no organic disease. There will be no damage or destruction to the retina or to any of the macula or any of the eye apparatus. But there will still be partial and transient reversible loss of vision. Now, the thing is, I'll talk to you about the pathogenesis. See, it was the prime time of Akbar, Amar and Anthony in the initial 5 years when their eye was developing, right? Both the eye pathways were developing, the brain was developing, the optical path was developing, the brain was accustoming to this optical path. But during this path development, the person or these people had one damage to the eye. They had, damage to the eye, like to the cataract eye and the congenital cataract eye, the anisometropic eye and the squint eye. These eyes were not able to recognize that pattern of growth. The brain was not able to coordinate with this damaged eye, right? So when these people got the surgery of congenital cataract, anisometropia and squint, even if it was repaired, still the pathway was not, made completely clear. In the prime time of 0 to 5 years, then these people will have transient loss of vision, because the brain is not able to accommodate to this new exit which is not coordinated. So basically, the pathogenesis has some certain factors. That is, if the person is not able to use the eye normally till the age of 6 to 7 years, and in the initial 6 months of life, which is the extremely crucial time of life where the optic pathway is being produced, the optic pathway is being coordinated, that time if this eye is not functional, after that, even if you were to get the eye repaired, the eye coordination does not work the similar way it has to work, and there will be transient reversible loss of vision. Now, it usually does not develop after age of 6 to 7 years of age, and the deviation during normal development. So yeah, the whole essence is that there is deviation during the normal development in the eye, which so the main point, the point of ignorance which had to be countered was, if they got this squint or congenital cataract repaired in the earlier days possible, if they got it treated in the earlier days possible, then there would be no problem such as amblyopia, where there was transient loss of vision. Now, what are the umbiliogenic factors? If you're talking about umbiliogenic factors, you have light deprivation. That's there will be decreased light. See, if there is congenital cataract, there will be less light coming in, so that's why it will be light deprivation. Squint, if one person has one eye which can normally fixate to a point, whereas the other eye which is having a different angle, then he'll have squint. And if he is having squint, what will ultimately happen is one eye will not be able to fixate, so he'll leave that eye you will always try fixating from one eye, by which what will ultimately happen is the other eye's pathway is again distorted and disordered. Anisometropia. So anisometropia is a condition in which one eye has like a specific refractive power, whereas the other eye has a very different refractive power, because of which there is difference in refraction and there is difference in image formation. So in one he has to stress more, at the same time try to focus more, whereas in the other one it is very easyable. In the other eye it is very easy to focus on the subject or any topic. Now what are the types? So it could be strabismic amblyopia. Yeah, what is strabismic amblyopia? Because of squint, right? In one eye there will be squint, the other one will be normally be able to fix it. Then you have stimulus deprivation amblyopia. Yeah, so if there is less stimulus, as I told you, like if there is congenital cataract and if the pupil is closed and there is no light penetrating, there will be no stimulus, because of which the person will not be able to recognize. Then we have anisometropia. Yeah, one high refractive, highly refractive power eye, whereas the other one being normal. You have anisohypermetropia is a greater problem than the anisomyopia. So that is one thing you have to take care of. That is one point you have to remember. Then you have isometropic and ambiliopia. What this means is, bilaterally the person is having same amount of refractive error. Now it could be hypermetropia, it could be myopia, it doesn't matter, but it is uncorrected. These people who never take care of their eyes, even if it's not visible, they're still trying to focus their eyes with the same refractive power. They're not buying glasses, or at the same time trying to get it repaired or corrected. Then we have something called as so those people, so isometric, anisometric, then you have stimulus deprivation, and then you have amblyopia, strabismic amblyopia. Then you have meridional amblyopia. So if a person has uncorrected astigmatism, so we are going to the lens disorders, or a lens which is more cylindrical. So in that kind of a condition, or if it has non-uniform refractive surface, so the person will have astigmatism, and if this astigmatism is not corrected, then the problem will end up causing meridional amblyopia. So if the person is having a power greater than 1.5 diopter, and if it is uncorrected type of astigmatism, he'll have unilateral meridional amblyopia. Whereas if the power is greater than 2.5 diopter, then he will have uncorrected astigmatism, but this time it will be a bilateral meridional amblyopia. Simple funda is that if it's greater than 1.5 diopter, it's unilateral. If it's greater than 2.5, it is bilateral. Talking about the clinical features, see, the person will have decreased acuity of vision. See, of course, right? He's having a transient loss of vision, and this time acuity is the bigger problem, and he will not be able to recognize than resolute. That is like Amar, Akbar and Antony will not be able to recognize their friends or parents, rather than resolving to the details which are present on their dresses or something like that. So they'll not be able to recognize rather than resolute. See, we could classify this amblyopia based on the visual acuity into 3 grades. One would be mild, the other would be moderate, and the other one would be severe. When you're talking about the mild, if the person is having a vision of 20 by 25 to 20 by 60 diopter, then it would be a mild type of amblyopia. Likewise, if it is 20 by 70 to 20 by 100, it would be a moderate amblyopia, whereas something greater than 20 by 200 type of vision would be a severe amblyopia. 20 by 25, 20 by 70 and 20 by 200 are the lower limits. Now talking about neutral density filter, there would be a specific filter called as neutral density filter, which you are going to use to test the amblyopia. So if suddenly a person comes to the OPD saying, hey, I'm not able to, I'm sudden, everything seems correct, but I'm not just able to look at things, and I have problems with, recognizing rather than resolving, and it is transient. So what you will do is you'll give them a neutral density filter. And if after giving a neutral density filter, it will have all these like stripes kind of thing on it. And when you give that, in amblyopia, the person will have an improvement by 1 to 2 lines. So there will be deviation from the, standard value to 1 to 2 lines. But when you have this organic lesion, if the person is having some condition like could be, you know, cataract, could be astigmatism or something like that, and it has not been corrected, then he'll have decrease in vision. So in amblyopia there is improvement, whereas in the organic lesion there will be decrease in vision, right? So this is the neutral density filter funda. Then, so there is a specific type of acuity in this amblyopia. So there will be something called as crowding phenomena. In which the person with amblyopia will, you know, he'll be able to see better on the optotype chart than Snellen's chart. He'll be able to see on a optotype chart better than a Snellen's chart. So that would be called as crowding phenomena. Then we have something called as amblyopia. So there will be something called as eccentric and central type of fixation. There will be something called as eccentric and central type of fixation. So the degree of amblyopia, the degree of loss of vision, is directly proportional to the distance. It is directly proportional to the distance of the subject or the object which you are trying to focus. So let's say something is far away, you will have more amblyopia, you will have more transient loss of vision or more loss of recognition. If it is very near to you, then you will have less amblyopia, right? So then let's talk about colored vision. Colored vision is not distorted much, but if a person is having a vision less than 6/36, then it will be affected more in deep amblyopia. Amblyopia does not change too much of colored vision, but if there is 6/36 type of, you know, vision which is less than 6/36, then it is affected more in amblyopia, right? So clinical features, a crowding type of phenomena where you can see more on the optotype chart. Then you have the neutral density filter which kind of improves in amblyopia. At the same time, you could categorize it into three things: mild, moderate and severe. Then at lastly you have something called as the colored vision being affected and the eccentric and central type of vision, right? Now what is the treatment? We have spoken about the types. Let's talk about the treatment. So the catch is simple. Amar, Akbar and Antony were, you know, having this damaged eye for a long time, till almost 5 years of their age. That was the ignorance what their parents showed towards their one eye. So the treatment is try to, you know, repair that first. Try to, you know, repair that refractive error or congenital disorder first, and make sure that the eye is corrected, because of which the brain will accustom through the optic pathway, right? That is one point to it. Now correct it. But after correcting it, you have to do something more to that. That is called as occlusion therapy. You have to do something called as occlusion therapy. But whatever you have to do it as soon as possible. ASAP, you see, right? Now the occlusion therapy, so you have taken care of all the refractive errors or any congenital conditions. Now we have to do occlusion therapy. What you have to do is, if the person is not able to fixate very well from the corrected eye, the eye which has been repaired recently, you start occluding it. What you do is, at the same time you occlude it, but at the same time you have to even occlude the normal eye. So I'll tell you what it is. Using a gauge pad or a Doyne's rubber occluder, you have DRO, just remember it, DRO. Through a Doyne's rubber occluder or a gauge pad or an opaque contact lens, what you do is, you occlude the normal eye. Once you occlude the normal eye, what happens is, the person will start, you know, suffering, and he'll start, you know, that will be a stimulus by which he'll start using the corrected eye, the eye which was corrected. That is the amblyopia eye, by which he'll start focusing using it, and there will be more effort, by which there will be more connections to the brain, right? Now this occlusion therapy using a, you know, gauge pad or opaque contact lens could be done in many types. One is you have something called as part-time and then full-time. Full-time is basically during the waking hours. During the waking hours, you have schedule. You have to follow a specific schedule. That is, you know what? So in this waking full-time therapy, you cannot close the whole of working eye. Now the working eye itself is closed multiple times, means that will start acquiring amblyopia. So what you have to do is, you have to follow a specific type of schedule. At the same time, you know, make sure that the normal eye, which is normal since the beginning, gets some rest, like some 1 hour of rest or 2 hours of rest. Now talking about the schedule, So for 2 years, it is 2:1 ratio. 3 years, it is 3:1 ratio. 4 years, it's 4:1 ratio. And 5 years, likewise, and 6 years. What happens is, for 2 years, people, 2 hours, you have to close the sound eye, and 1 hour, you have to close the amblyopia eye. Likewise, for 3 years, you have to close the the sound eye for 3 hours and amblyopia eye for 1 hour. For 4-year people, you have to close the sound eye for 4 hours and then close the amblyopia eye for 1 year, right? It's like alternate. Close the one eye, which is the, what do you call, the normal eye, then you have to close the amblyopia eye. So in part-time kind of occlusion therapy, what you do is you basically close it for 4 to 6 hours in a day. It's just part-time, doing the same occlusion therapy for part-time, right? Now, you can't keep occluding the eye for a long time, right? If you keep doing it, what will happen? Either one eye will start developing amblyopia, or there's no use of it. So you do this occlusion till there is 3 months. Still 3 months you keep doing it and still there is no improvement, then you stop the occlusion therapy, or till the visual acuity increases, by which the person which was having amblyopia, the eye which was having amblyopia, starts developing visual acuity. Or you do it till 3 months, and if there is no improvement in visual acuity, you do not do it at all. Then you penalize. So the other way of treating it is penalizing. So penalize basically close the normal eye with so the penalization could happen in 2 ways, okay? Optic and atropine. So you can put a big thick fat glasses to the normal eye, so that again you have penalized that eye, and the amblyopia eye has to start working, and then you blur it. You blur the normal eye with atropine, by which there will be, what do you call, the amblyopia eye has to start working. Then you have to do some pleoptic type of exercises. These are eye exercises basically. The pharmacological action is this levodopa or carbidopa combination, which seems to be an adjunctive type of therapy. It seems to be an adjunctive type of therapy, which has been very helpful in the recent times. Then you do something called as perceptual learning, or perceive it, or do some exercises basically. Then you have computerized active vision therapy. You do a computerized active vision therapy.